let's join Sivakumar, I think, if he's ready. Shiva?
Every day, a large number of people, both children and adults, experience medical intervention and care at Triple M. They walk in through the doors of Triple M as patients and walk out with a new lease on life. The Madras Medical Mission Hospital, since 1987, has been synonymous with excellence in patient care and quality medical treatment at an affordable cost, and it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The catheterization lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at Triple M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.
Right. Good afternoon, Shiva. We can see you.
Yeah, thank you very much. So I have my colleague Dr. Pramod with me starting the case, and I have Srija, my long-term associate for imaging, assisted by Dr. Rohit Raj, and Dr. Ashish, one of our senior fellow, will now present the case. There was a minor change because of the COVID-related scheduling differences. We are going to be showing a patient who has large aorta or left atrial fistula post mitral valve replacement. Dr. Ashish, can you show the PowerPoint presentation?
Yes, sir. 50-year-old male. He was diagnosed to have RSD and severe MR.
Is it audible, check?
Yes, yes.
Okay.
Developed culture positive infective endocarditis and treated for 6 weeks with appropriate antibiotics. Underwent mitral valve replacement with 31 millimeter Biocar valve. Intraoperative TE saw some abnormal flows from aortic root to LA, but it was accepted as a sutural paravalvulic. On repeat post-operative day 3, they confirmed that it's a aorta to LA fistula. Post-operatively he is having developed an NOHA class 2, progressive pericardial effusion, pleural effusion, and congestive heart failure on requiring high doses of diuretics. On examination, weight is 69.7 kg. Blood pressure is 110 by 60 millimeter mercury. Pedal edema is present. JVP is elevated. Cardiomegaly. Continuous murmur in the left upper sternal border. Loud P2. Excess word right pleural effusion. Sternal words are present. Dilated LA and cardiomegaly. ECG showed sinus rhythm. Left axis deviation with left atrial enlargement and prominent left ventricular forces. Echo showed right pleural effusion and pericardial effusion with dilated LV. On color Doppler there is mild tear, and on apical 5-channel view we can see the aorta to LA fistula. On long axis view it is shown that it's from the NCC to the LA. Its measures around 8 to 9 millimeter in size, and there is a continuous flow from to LA. The short axis also confirmed the same defect. We performed a TE. This is the apical this is the 4-chamber view which showed the fistula. Short axis also, this is explained in the short axis and long axis, which is showing the fistula also. This is the 3D echo which showed the fistula from the NCC to the LA. Now, while performing the surgery, after the suture has been passed from the LA to the NCC and it has come back. So after the putting the valve, the fistula has been created. So the final diagnosis was post mitral replacement of the bioprosthesis valve. There is a LA tissue weakened by previous staphylococcus endocarditis, aorta to LA fistula postoperatively, heart failure, there is mild PH, LLV dilatation, and mild bimetrical systolic dysfunction. So our plan is to close this fistula. Thank you.
Shak, you heard the presentation by Dr. Ashish, and Dr. Srija has much more spectacular images today morning, and she is presenting the live echocardiogram, because most of the information is there on the image only. So can you show the echo big, Srija?
Yeah. Good morning. Am I audible?
Yes.
Okay, thank you. Briefly taking you through the images, live TE images in the lab. So this is a 0-degree view which shows a dilated left atrium and left ventricle with a normally functioning mitral bioprosthesis. We are already seeing a communication somewhere from the aortic root which is opening into the left atrium. So on color interrogation, we are seeing a continuous high velocity flows which are entering into the left atrium from the aortic root. The mitral bioprosthesis is functioning normally with a trickle of leak. This is a 3D zoom image looking as viewed from the left atrial side, which shows the left atrial exit of the fistula.
Can you use the cursor to show that? Oh.
Yes.
It is in 2 o'clock to 3 o'clock position, somewhere at around 2 o'clock position.
Yeah, cursor is not moving actually.
Point. Okay, never mind.
Somehow cursor is not working.
Cursor is not coming to the.
Yeah,
okay,
yeah.
Carry on.
Okay, carry on. Yeah. Next picture.
So it's now.
It's at 2 o'clock, Shak.
Around
Somewhere
2
between 2 to 3 o'clock. Yeah.
Yeah.
So now we are seeing the color flows across in the fistula. Now we can see it's around the 2 o'clock, 3 o'clock position. The left atrial exit was measuring around 8 millimeter. So he had seen clearly with a little bit more of a zoom. And on a 120-degree view, this is the exit from the fistula from the non-coronary sinus into the left atrium.
Injector.
And aortic regurgitation, there's a very tiny whiff of aortic regurgitation, nothing major. So that is the fistula which is seen in the 90-degree view. It's a zoomed image. The aortic side of the fistula was measuring around 10 millimeter. And on a 45-degree view, we can see the fistula opening there. This cursor is not moving. With the color flows, the fistula, the aortic orifice of the fistula is from the middle of the non-coronary sinus.
25 ml at 18 rate.
And that is the measurement from the aortic end. It's around 10 millimeter. So since it's 10 millimeter, the aortic end, we are targeting a device to cover the defect from the aortic end. This is a live 3D image which is showing again the fistula from the left atrial side. And we can see it from the aortic side. It's not a very...
Yeah, it's from the middle of the non-coronary cusp. There is an orifice, which Dr. Srija nicely showed that the entry point was almost close to 9.8, 9.9 millimeter, a little less than 10 millimeter. Shak, what we had till now done was we took an femoral artery and femoral venous access, and the pulmonary artery pressure was 45 millimeter systolic when the aorta was about 90 millimeters systolic. This is the current hemodynamics. So now, how will you approach the situation, Shak? I will.
Very good. Yeah. So let me just ask Gianfranco and then some of the panel members. Gianfranco, very briefly and quickly.
Camera.
Interesting, rare problem.
Yeah, that's a very interesting problem. Thanks for showing us this case. I cannot really understand exactly how is the relationship of this fistula compared to the coronary cusp. Is that, I mean, the exit point, is that passing under the coronary cusp or above the coronary cusp? and probably it is not going to
show
be
it on a
easy
long
to
axis, Srija.
understand.
We will show that, Gianfranco, now. Actually,
Yeah.
on a long axis, you can clearly see that it is from the aortic root. It's from the aortic root. It's a continuous flow. If it had been from the left ventricle to the left atrium, it will be systolic flow, whereas this is a continuous flow. Srija, get a color across and rightward rotate. You see that?
No, the point is that to understand how the cusp is related to the fistula.
Now
or
show
if it is part of the
short
of the
axis
tunnel itself.
It was from the middle of the non-coronary cusp. It was well away from the leaflets. I think the 3D picture that
is showing it.
I think, Srija, it was some 27 or 28 image where you showed it was in the middle of you see, now this is a beautiful picture. This is now showing the left atrial side. Now Dr. Srija is slowly tilting. You can see this is the aortic side. So this is exactly, the pointer is on the aortic side. Srija, gently shift and show the cusps now. Show the aorta in en face.
Can you make that image bigger, Shiva?
Yeah, make it larger. Put on zoom there. Okay. Echo big. Okay. Now okay, Srija. Okay. Now that is actually in the middle of the non-coronary cusp. Srija, rotate it again and get the leaflets for them.
No, this is not a live 3D.
No, en face the aorta. Just push it. Your rotation. They are correct. Exactly. Little bit more. And now give more gains, then you will see the cusps better. Yeah, you can see that the aortic leaflets are little thin. So when we give more gain, there is lot of dirt around in the aorta. But it is in the middle of the non-coronary cusp and it is exiting. The cause of this fistula possibly was a weakened mitral annulus by the infective endocarditis, and the surgeon operated immediately after treatment of the infective endocarditis. And in the long axis view, she was actually showing it so beautifully. The picture number 19, 20, Srija, 19. So this we can appreciate. You can see that basically there probably was like a perimitral root abscess. And the aorta is now entering into a sac. We can appreciate the aorta below entering into a sac, and the sac is exiting into the left atrium. Right now we did investigations, and last three...
Shiva, the main question Gianfranco, I guess, is referring to is how much impact there will be of a device on the aortic valve leaflets.
But since it was in the middle of the sinus sac, our device is going to be sitting on the cup portion of the sinus and not going to be closer to the leaflets at all. You see now here, in this particular image, you see the leaflet, the two commissures, the non-coronary, left coronary commissure.
Give a comment?
Yeah, Nageshwar, yeah.
Yeah, Nageshwar, go ahead.
Good evening. Nice to see all of you. We had a similar situation. Shiva also knows last year we demonstrated that in a child with pulmonary root translocation in a complex double outlet right ventricle.
Angiogram.
This is more or less similar.
Picture big.
But here advantage for you is we should close this. There is no doubt about the indication because the amount of shunt is quite significant.
Inject 25 to 18.
Paravalvular leak, whatever it is, iatrogenic paravalvular leak from aorta to LA. Whether you want to close retrograde or you want to close transeptally is the major challenge here. I think
slightly pull out the probe. Pull out
situation in order to assess the aortic function, you need to have constant TE which is there, and the defect is far away from the leaflet. I don't think you will interfere that. You can go into little bit of the cusp of the above the cusp of the aorta. So we can actually close either from retrograde or transeptal puncture and then do it. The advantage of...
Yeah, Nageshwar, we've lost you.
Yeah, Shak, I agree with Dr. Nageshwar's point. We can close it retrograde from the aortic root or antegrade from transeptal. The advantage of doing it transeptal will be basically it's a sinus of Valsalva fistula, and we have a fair amount of experience of sinus of Valsalva fistulas that usually enter into right atrium and right ventricle being closed with a duct occluder because aorta is a high pressure and the other chamber is a low pressure. So a conical device fits in well. So our intention will be to try to put in
Shiva.
Yep.
Yeah, hold on. Alain, I'm just going to ask Alain first because he wants to comment as well. Alain.
Yes, thank you.
Very
I
quick.
think I agree about the technical consideration that has been raised, but we have had also a similar case like that. And my question would be, our question at this time was, how far are we from the infection? Because this patient had a non-localitis. When we consider putting a device, of course, a pulmonary valve, but other type of device in the patient who had a recent history of endocarditis, we want to put sometimes away. So I wanted to ask first if this patient, I mean, how far are we from the infection, and also is that the timing, if we are too close from the infection, to go ahead and close this.
Yeah, yeah, Dr. Alain Frey's, it is the infection was in the month of June, early June, and he was treated in early June. Following that, he underwent mitral valve replacement, and after the mitral valve replacement, he was continued on antibiotics. Last 3.5 months, he has been afebrile, and all the blood infective markers were negative.
Okay, Shiva, carry on now. It shows what you.
So we will, as we were talking, as Nageshwar was telling his views, I took the aortic root angiogram. Show the first picture. This is in an AP projection. We can appreciate a large filling of the left atrium. We can appreciate the small protrusion from the non-coronary cusp just beneath the transesophageal echo probe. Then this was in an AP projection. You can also see the Biocar valve, which is a St. valve, which hardly is seen, just like a rim. The second one was in an RAO projection where we pushed the.
I was going to ask whether you were using the TOE probe as a marker.
Yeah, the T probe was subsequently pulled up, and you can appreciate here. This is the fistulous entry point and the flow into the left atrium. Now, what we are planning to do is actually, if it is a retrograde closure, we have to use a double disc device, but if it is an antegrade closure, we can use like a conical device like a duct occluder. Since most of the world's experience with sinus of Valsalva aneurysm is using a duct occluder device, we also prefer to do a duct occluder device because it is smaller in its profile on the left atrial side. And naturally, we need to have a transeptal puncture. So as we spoke to you, we had advanced the needle. Now we are live. So this is going to be echo-guided and fluoro-guided. We are coming down.
Whilst you're doing that, there's a question from Sebastian about whether you would consider an MFO occluder deployed retrogradely or not.
Okay. Just after the puncture, I will tell about, we discussed about a non-self-centering device such as an ADO2 or an MFO versus a self-centering device like a muscular VSD or a duct occluder device, and we tended, we finally decided. Can you rotate and show the puncture points, Srija? There. I'm indenting. You put the explain on the indentation. Explain on the indentation. Yeah. No, okay. So you are able to see the indentation on both the echo big.
Yeah.
Yeah. Are you able to see the echo?
Yes, we can.
Okay. So I am making a puncture. So I have entered the left atrium. So I am pushing my Mullin sheath deep inside. I am withdrawing the. This is a 7 French standard Cook Mullin sheath with the broken bro needle BRK1 and sister 5000 heparin in. 5000 heparin. So now I will show the left atrial pressure. The aortic pressure now is, show the hemodynamics big. Show the hemodynamics big. Okay, the aortic pressure is about 90 systolic. He is under anesthesia. This is the left atrial pressure, which is a mean of about 20, somewhere around 20 to 21. Can you see the hemodynamics there?
Yes, we can.
Yeah. So the next step will be, we will okay, the Sebastian's question about usage of devices. The ADO2 device as well as the Conar MF device, both are non-self-centering devices because they have got a tiny waist. So the waist, if suppose if it goes into one of the corner of this 10 millimeter leak, sometimes it may so happen that the leak may not be fully be closed. So we wanted a self-centering, device. So our preference will be either a muscular VSD device if you are going retrograde, but if you are going antegrade, as I mentioned earlier, our tendency will be to use a duct occluder device. So here I am exchanging this pigtail for a Judkins right coronary artery catheter. We probably will be going back to the RAO view, where show me that RAO view and the previous fluoroscopic projection. So we will get into the same projection. This is
I had one question for Shiva.
Yes, Dr. Bharat.
Shiva, my question to you was that what do you estimate as the length of this track? Do you have any concerns that ADO1 may not be of adequate length to take care of the length of the track?
Okay. Now show the echo big now.
Small little fenestration, because one of the views.
Sure. Bharat, now we are showing you live the echo. Srija,
this is the view I wanted to see, and I want to estimate the length of this track.
Srija, measure the length between the entry point to the exit point. Yeah, it's somewhere around, no, but that is the transverse, Srija, the entry point to the exit point. Again, show the echo. Show the echo big. Echo alone big. Yeah, Srija, from the entry point to the exit point takes almost like a vertical diameter. That's enough. Okay. Okay, that is the exit. Come down, little above. That go to the middle of it. Yeah, Dr. Bharat, it's somewhere around 5 to 6 millimeters. But if suppose if I give a pull on the device, Bharat, what do you feel? Give a fluoro.
No, because of the length, I had a little bit of a concern. But I think if it is 5 to 6, you may just be able to have both the ends well covered with the device.
Yeah.
Now if we can make the fluoro bigger.
Fluoro bigger.
Shiva.
Yeah, fluoro big. Fluoro store this and show the fluoro big. Run this movie. So now I'll show you live shack. We have entered the sac, and now I am advancing my right coronary catheter inside. I have made a loop of. Okay. Now,
and that's a Judkins right and a Terumo wire.
Yeah, Terumo angled glide. Yeah, Terumo wire. So now on this side I am taking around, it's a 20 millimeter snare through that Mullin sheath that we have. Mullin sheath is recording around 21 millimeters of mercury mean LA pressures. RA pressure was around 10. He has some amount of pleural effusions, pericardial effusions and all. Okay, so now here.
If you're using an ADO1 device, and Bharat's question or concern about the length of the connection, you could use the long shank Occlutech device then, couldn't you?
Long shank, yeah, that also should be possibility. Take it out and then advance.
You almost need a 40 millimeter snare.
Yeah, advance. Okay, now. Can you open it and re-enter? Just a second.
Whilst you're trying to snare, Bharat, are there questions from the attendees we can address?
It's a little larger, around 10 centimeter left atrium.
Most of the questions have been asked, Shaq. The only question which one of the attendees was wanting to know that do we have any concerns about conduction issues after the device? I'm not sure exactly how is this communication with respect to the conduction.
Yeah, it is possible, Bharat. Actually, the non-coronary cusp is actually on the right fibrous trigone, and hence, yeah, that's a point that we have to think about. We do have a concern about it. However, there is oh God, okay. However, we have to deploy it, and then we have to see what is the. It is true that concern is true. It is. I lost the.
Can I make just a comment about the choice of the device?
Yeah, go on, Alain.
Yes, so I think first I totally agree with you, Shaq, about the long version of the Ocutec, and also because of the proximal shapes that will match well the diameter of the fistula. One consideration with this fistula, it's very tortuous. In the case we have had, the echo underestimated the length of the fistula, so it was longer because of the tortuous route, and this is why we ended up using non-planar vascular plug 2 in our case. Also because we were quite close from the cusp, and we didn't want to have a disc protruding in the aortic side of the defect.
Yeah.
May I make a comment?
Yes, please.
Yeah, exactly, because the shape of the fistula is quite complex. I would propose, if you do agree, to make kind of sizing or shaping of the fistula by using a soft balloon catheter that could be probably around 10 millimeters, and then just inflate very gently across this tract to have the shape from inside, and to exactly see if there is any interference with the surrounding structures.
So, Shaq, the question is, how many of the panelists would suggest a balloon sizing of this fistula, given the information that this, get the sheath, given the information that this is post-infective endocarditis, little friable tissue, so would you like to have balloon sizing, or would you like to go just with an echocardiographic assessment and oversize the device by maybe 2 to 3 millimeters larger?
So Gianfranco would go balloon sizing. Alain, what would you do?
Well, it really depends. My personal view in this situation, because my first intention device would be a non-planar vascular plug, and it's not a very expensive device, and it also has it's very soft, so it will allow to have, in case it works, we are fine. In case it doesn't work, it will also allow to have a very accurate idea of the shape and of the sizing of the fistula. So I would do either balloon sizing, following the idea of Gianfranco, but I agree with the concern in a very tortuous fistula. If you have a 90-degree angle, I'm not sure the balloon sizing will provide also a very accurate description of the shape. But then you can also speculate that a soft device would do the job.
I would size this using devices. I wouldn't balloon size. So you're almost using the devices for sizing. and rely on the echo images because of that concern about increasing its size. Is Dietmar with us?
Yes,
yes.
I hear you very well.
Oh, good. Welcome. And so what do you think? Balloon size or not?
I would size it in any case because I have no other experience other by sizing, and I feel me more comfortable to have a sized, let me say,
fluorostor.
You know, could you follow?
Yeah, yeah. Okay.
Thank you.
Hi, Dietmar. Nice to hear you.
I'm always happy to see you.
I thought you had not logged in when I didn't hear your voice.
It's very unusual for Dietmar to be quiet, isn't it? Yes.
So what?
The procedure is so great. I'm astonished.
So Shiva, on TOE, now that the sheet is through, are you going to reassess the color flow and see if that gives you some idea of the sizing?
Yeah, echo big. Echo big.
And what French sheet was that? Just remind us.
This is an 8 French sheet, Shaq. 8.
Because you have already decided what kind of device you want to use.
Dietmar, the discussion so far had been, Sebastian discussed about a non-self-centering Conar MF device, which I was not happy to use because I want a device that will be centered on the aortic exit, aortic orifice. That means the 10 millimeter orifice, I want to have a snug fit. So because of that, I was not very happy about MFO device, and the same principle probably goes on to the Amplatzer vascular plug 2 that was proposed by Alain Fries. As I told you earlier, my choice of devices should be self-centering. It should fill that aortic 10 millimeter entry point, and that will be possible with either a muscular VSD device or a ADO1 device. Now, having seen that it is a 10 millimeter orifice, Srija, is it any big now than what it was previously? So, being a 10 millimeter, my original plan was to take a 1210 PDA device, 1210 ADO1 device, but I am just wondering whether, I think that should be okay because the exit orifice is only 8, and so I should be able to get a 1210, and in case if I fail, then I will again recross and then try to put a 1412. Now I have a 1210 device. Dietmar, what was your thought process?
I would prefer VSD, muscular VSD occluder.
Yeah, that's true. Actually, muscular VSD device was another device that we strongly considered. Of course, it is a little less expensive device, that is one. And number two, since it is from a very high pressure channel to a low pressure channel, we felt that it should be okay to use.
I think yeah.
But
you are more experienced with this. But I would use from the security point of view with muscular VSD occluder.
Yeah, Dr. Bharat also raised the issue of the length of the sheath being not fully adequate, and hence length of the device being not fully adequate, and whether it will create a difficulty in sound French sheath, whether it will create a difficulty in the exit orifice coming into the left atrium. Sound French sheath. So you've
Shiva,
yes.
Shiva, we missed you've attached the device and it's the 1210, is it? Yes.
Yes. So it's a 1210 PDO device, Shaq, and I tried to load it onto a small 6 French sheath, which obviously is not compatible because the 1210 needs a 7. So I opened another 7 French short introducer, and now I am loading it. Okay. So this is a 1210 ADO1 device. Flush it, sister.
The question is that this is such an unusual case.
Yeah.
Why are you not for balloon sizing the defect? It can.
I can't hear you, Bharat, with the signal probably, but why not balloon sizing? The concerns really, the concerns really with recent history of infection, whether balloon will increase the size.
It is almost 3 months now, and he's
can you come to non-coronary? Non-coronary. Yeah, so Bharat, in general, in an infected tissue, sometimes if it is very soft, I can enlarge it a little larger and larger by putting in a balloon. Of course, you can always say that we can use a very soft balloon like a tie shack and have a pressure monitored and not exceed maybe about 0.5 to 1 atmospheres. Now I'm trying out with duct occluder 1.
Shiva, can we make the fluoro bigger?
Fluoro bigger or echo bigger? Because echo is going to be more informative, I thought.
Oh, okay, then, yeah, all right then, because we can't see much.
Okay, can you put a pigtail onto the aorta? Just a second. I will get a parallel pigtail into the aorta so that I will have a just a wire. So we have got the aortic retention skirt into the ascending aorta, a short distance from the okay. So this is the land.
May I have a comment to the PDA, the EDU1?
Yeah.
Yeah.
Would the EDU1 a little bit too short to the unmeasured length of the defect?
Yeah, very good question, Shiva. Dietmar, we answered that earlier on.
Yeah, actually, Dr. Bharat raised that issue, Dietmar, and can you show me on RAO? So now I'm.
Could it be marked out? That is my question.
Srija, can you show the device? Rotate and show. Okay, we are coming closer to the orifice. Make a test angio here. Can you see the device that is coming close to the So
when you do the test angio, if you make the angio big and then go back to echo big.
I will do that. I'll do that. Give a small injection, about 15 ml at 18 rate.
Light is coming on.
Make the angio bigger. Okay. Okay, I have a little bit more length to go. I even on the Srija, concentrate on the device. Show the device continuously.
Now you can make echo bigger.
Echo bigger. Okay, Srija, are you able to show me the device, like rightward rotate and get the fistula now with the color? Okay, further right. Okay. With the color compare, can you put it? Yeah. Yeah. Okay. Now, can we make another angiogram? Make the angio bigger.
It's better.
Okay, ready? Huh? Okay, still I have to come a little bit more.
Yeah.
So be there. 1 second.
You feel any resistance at the moment?
Yeah. Some amount of resistance. So now I will do one thing. I will start deploying at this point.
And make echo bigger.
Yeah, I'm seeing a waist on the device.
That's a good sign.
I have made. Okay. Now we will do one angio. Yeah, true. I will try to go into the non-sinus itself so that I get.
Some small response.
Okay, ready for injection. Give a good amount, 20 ml at. $20 ml. Yeah, there is a waist of the device. It looks like I have probably exited into the left atrium. It is looking like a miniature muscular VSD device now. Show the.
So, Gianfranco, what do you think?
I think, the shape of the device is quite okay, but there is quite a significant aortic regurg. So there is some interference with the.
Can you get it on a long axis view and see the aortic regurgitation, Srija? Yeah.
Can you look the leaflets with the echo?
Lot of color split.
There is a lot of color. Here, I think the color gains are too high.
I didn't change anything.
Once you go on to the color, reduce the color gains. It's everywhere color is there. Reduce the color gains. Reduce.
Did you catch the...
No, it's too much of color gains. Just keep on reducing the gains till... No, your scales are going very low.
Scales, scales.
Scales and gains also. There is a gain button.
Yeah.
Gain.
The scale is very low, 67 centimeters per second.
Yeah. Reduce the gains. Keep on reducing the gain. Correct. Okay. In a little bit more.
Also do a split screen echo. Yeah.
Okay.
Yes.
Now, little bit also you can reduce the color gains. Actually, even now the color. Now the question is.
From angio, the verge looks very eccentric.
Yeah.
So echo will be a bit difficult too.
Maybe you have caught the valve for that.
Okay, can you, now the valve leaflet, the posterior leaflet, now can you, Srija, just to show the leaflets better. Okay, the leaflet that is what you are seeing posteriorly is either the left coronary or the non-coronary. Srija, can you rightward and leftward rotate and keep showing the...
Can I go to a short axis?
Yeah, can we see a short axis?
Yeah, that's
short axis.
Better, yeah. So I think that cusp is caught,
cusp is caught,
yeah.
Right?
Yeah.
Okay.
It's fully caught into this.
Fully caught,
yeah.
Okay. Go inside little bit. Okay. Yeah, we are not able to see. Can you color now? Yeah. Okay. So what I will recapture the device and then we will see how things look. Okay. Now I have gone into the aorta again. Now we are able to see the leaflet.
Yeah.
Okay.
Yeah, that's disappeared.
Okay. So now.
Yeah, this was my concern at the very beginning in some way.
Okay.
So
can you now get a long axis? Probably now Alan Frey's suggestion of a softer device like a vascular plug.
If I could suggest something, probably I would go for the idea of shaft with a long shaft occludec, but implanted in the opposite way with the umbrella on the on the
aortic side.
On the ventricular side, and the shaft on the aortic side, because then you will have no discs in the aorta, while a kind of retention mechanism anyway.
If you do it that way, you'd really have to oversize it quite a bit to stop the shank from being pushed into the
Srija, can you show me where my is my cusp in the right coronary cusp or non-coronary cusp? The pigtail catheter. Pigtail is in the non-coronary. So I will try to rotate it and get it into the...
Was in the right coronary.
Yeah, I want to enter the right coronary.
Yeah, now it's in the right coronary.
I want to enter the non-coronary. Is it right only?
Is Nageshwar back? Because I think he had to go. Nageshwar, are you back? No. Alain, any further thoughts at the moment from what you've seen?
Yeah, so I would now definitely go with...
show me the leaflet now.
With a vascular plug 2. And you can try it retrogradely because it's a very soft device, and even if you cut the leaflet, you can pull it a bit, probably.
Srija, are you able to see the leaflet now?
Yeah, I'm seeing some leaflet here.
The leaflet.
But what?
No, I am trying to open the device.
And what size would you pick, Alain?
Yeah,
can you give another injection?
3-4 millimeter above, because this is the disc are all the same size. So I think the defect was measured at 9-10 millimeter. I would go with a 12 or with a 14. I think the length of the 14 is 2 millimeter longer than the length of the 12.
Now it looks good, Shiva.
I am trying to open the disc now.
Yeah, Shiva, now there's no aortic regurgitation on that angio.
Looks good.
Okay. I have got more device pulled in.
Now it is fantastic. It looks well on the color.
The leaflets are working. Now it's a question of working out whether the leak or residual flow is acceptable or not.
Yeah, sorry, this is also my other concern. You know, I brought the tortuous shape of this fistula, and now you have implanted a rigid device inside, which is larger than the fistula, but the orientation of the device may not cover all.
Can you give another 20? Okay. Alain, now you look at the pictures. You see that basically I am my cable is now pulling the left atrial skirt. So if I release my cable, there will be a little bit more memory retention by the device. You see the position looks okay to me. Can you show me a 3D on that the left atrial surface? Let us see how it looks. Now make it no, correct. Make it lighter and reduce the gain. Okay.
The part of the problem, Shiva, is going to be making that judgment of how much residual flow to accept.
Okay.
And if on release the device doesn't align itself and there is still a lot of flow, how are you going to retrieve it? Those are the sort of questions to help decide.
Yeah. In terms of stability of the device shack, what we have is a good waist formation. So the device is stable. The aortic skirt and the left atrial skirts are well aligned. Now I have given 7,000 heparin total. 2,000 initially when I took the vascular puncture, and then after the septal puncture 5,000. So it's a good amount of heparin that's going on. Can you show me the color now, Srija? Color. Yeah, it is not very bad. Shaq, you just keep watching there. Show on a long axis also, Srija. I'm going to make an angiogram parallelly. Should. Okay. Show the angio bigger. Yeah. There is.
That looks great. I think it will close.
Yeah, I think it should because the device probably will get loosened a little bit more when I release the cable. And moreover, obviously I cannot go further larger than this device because this device itself is having a good waist. And the second thing is the orifice would not have been perfect circle, it would have been subtle oval, and so it might take a little time for the device to mold itself into that.
Can you pull a little bit of the delivery cable and then make an angiography again?
You mean?
Yes, in this way.
Okay.
Yes.
Color.
Yes, this way. Now an additional.
It's distorting it, isn't it? Otherwise.
Yeah.
Color, Srija, the color, the leak.
No.
Shaq, I feel that if I use any sort of non-fabric device like vascular plug and all, still there will be same amount of flow because vascular plug may not have. Yeah.
I mean, to me, the main question really is whether you accept this leak and possible hemolysis later, or whether you go for a double disc device. Alain, you were going to say something.
Yes, I think it's a great implantation, and I agree that at this point you certainly should consider releasing the device. I share the consideration about the risk of hemolysis, and this is why additional reason I would have used possibly a soft device.
Now you could put a color again.
Where you are now, it looks a good result. And additionally, this is also why I would have agreed with Shaq, because the other option would have been a longer ADO, because you would maybe match a little bit better the shape of the of the fistula, and also the occlusec is a bit softer than the Amplatzer duct occluder. But I think it looks like an acceptable result.
Show me the color now. It is less color, make the color bigger. I think it should go away because the position of the device seems good. Color compare.
Yeah, the problem is we cannot predict which way the device will rest.
Yeah.
And that's the difficulty in decision making.
Yeah, but changing it into a muscular VSD. See, already my left atrial disc is a flared out shack, like more like a mini muscular device. Because you see that there was some amount of flaring of the device. Can you show me the device enlarged, zoomed? Mag it, maximum mag. Okay. And show me the device in profile. Go to Sri, just slightly pull out the cable.
Shiva,
the other direction.
Is,
other direction.
Till such time you are on such a stiff cable, it may not be very easy to find out as to the alignment of the device with respect to the fistulous tract, and you will never know.
Yeah.
Till such time it is released.
Yeah. So
as to how it is going to align.
I agree. Actually, so I am releasing now. So let me see the. Can you, Srija? Can you see the flow? Actually, there is not too much of change, Bharat.
Yeah, I agree.
In fact, one more thing that I forgot to tell you, I used a Trevisio cable in order to get some flexibility.
That color looks much more encouraging to me.
Yeah.
If you can make the echo big.
Yeah.
Echo big. Echo big. Yeah. Srija, there is too much of gains now. You see, everywhere there is color.
Flushed, no?
No, okay.
You are flushing, no?
Yeah. No, but reduce the color scales. I think the color gains. It's a lot of. It's because of color gains going up. Keep cutting down the gains. Now only it's correct.
Good. It comes.
Yeah, so that looks much better.
Yeah.
Super. I'm your fan.
Brilliant case. So Bharat, last 2 or 3 minutes, any questions from the attendees that we need to answer?
Time is over.
So one of the questions was what has happened to the? Is there any mitral regurgitation after?
Show the mitral valve. This is the mitral valve now. It looks good, Bharat.
One of the attendees wanted to know whether there has been any.
It's the same pre-existing mild.
Bharat, are you able to see the live picture? There is not much of mitral regurgitation.
Yeah, it looks good.
That's good.
And
it's getting better and better.
And Shiva, what has happened to the pulse pressure?
Okay, so show the hemodynamics big.
What has happened to the LA pressure?
LA pressure is now about 17. No, it's 17. I have given a 5-6 angios also, Bharat, and aortic pressure. Show the aortic pressure. It's around 16 to 17 LA pressure, and this is the pulse pressure. Not.
So diastolic pressure increased 20 millimeter of mercury.
Yeah, some.
Yeah. And can somebody put a stethoscope on the chest to find out whether the murmur is still there?
Sure.
Bharat, it's going to be very difficult to find a stethoscope.
Yeah, it is not. It's in the hospital's museum, and so we will try to retrieve one. And yeah, so Srija, once again, can you show the final color and the final 3D pictures?
Yeah, because we've got to go to Frankfurt.
And final.
Echo big.
Fantastic case. What have you done to make the cast free?
See, the first time when what happened was I put in the aortic entire retention skirt opened in the ascending aorta and I was dragging back. The second time I did not open. Can you show me that picture again?
Yes.
Show the previous fluoroscopy. make the fluoro big. Okay, previous. Go couple before. Correct. So basically, I got the disc inside the non-coronary cusp. My pigtail is now sitting in the right coronary cusp. So I got the entire device opened within the cup of the non-coronary cusp. The previous one, what I did was I opened it in the ascending aorta and I was dragging it all the way down. Maybe that was wrong. I thought that the distance within the non-coronary cusp is too short for me to manipulate, but then finally, this is the previous one. Can you show? Now you see that I am actually sitting in the non-coronary cusp, but my device is only opened like a small ball.
Yes.
So
there
then,
is no regurg.
and then slowly we opened it. Can you show 2 frames before the previous deployment? The previous deployment. Previous. One more. See here, I am coming full disc open.
That was a mistake.
Yeah, that was a mistake. In fact, here I am. My cusp is my pigtail is also sitting in the non-coronary cusp, and I am dragging it. I am dragging it all the way down. Yeah, probably I trapped the entire non-coronary cusp in this method.
Yeah.
Okay, Shiva,
very well done.
Absolutely brilliant
Excellent
case, very rare one, and very nicely demonstrated.
Thank you.
Thank you very much again.
Thank you.
And Frankfurt already, so we'll come back to you later on.
Sure. Thanks a lot. Thanks for the opportunity.
Congratulations.
Thank you.
Congratulations.
Get